Started. Welcome to the Department of Medicine Shapiro program. My name is Nasia Safdar. I'm the Vice Chair for Research and a faculty in the Division of Infectious Diseases. My own research is in healthcare-associated infection prevention, and it's mostly patient-oriented research in the inpatient and outpatient setting. So it sounds like pretty much everyone is interested in clinical research, which is what most of this introductory talk is going to be about. So this is the first of a series of several lectures. They're generally once a week that you'll be attending, and they are meant to supplement and not replace any of the other meetings and lectures that you're joining as part of your mentor's teaching. So today I thought we would start by just talking a little bit about how to develop a research question. Of course, you did that when you applied for the Shapiro program, but now that it's actually time to undertake it, there will be some iterations and some practicalities. Can we do it exactly the way that you had proposed, or does it need to be adapted or changed? So is everyone familiar with the PICO format? Yeah, so this, I think, is a really good way of making the question that you want to answer very specific, and it also helps to figure out what sort of study design will go into it. So for example, can someone, just using any of your projects, can someone tell me what their PICO question would be? You all must have written it that way, right, in your proposals? Or I can give you one. So supposing I want to look at the effect of probiotics on C. difficile infection in inpatients, what would a PICO question for that look like, do you think? We have all the time in the world. So in hospitalized patients, which is a patient population, the intervention would be probiotics, right? So in hospitalized patients, probiotics, and then the other thing that we often forget is what is the comparator going to be? So for clinical research, the comparator is very important, as it is for bench science as well. But here I have to decide then, is my comparator going to be no probiotics? Is my comparator going to be a placebo? Is my comparator going to be a different kind of probiotic? And then what's the O stand for? Outcome. And so what outcome am I looking for? In this case, I mentioned C. diff, but is it the first episode of C. diff? Is it recurrent C. diff? Is it additional things like hospitalizations or prolonged length of stay? So putting your question in a PICO format really helps you to solidify exactly the scope of the project. One thing with Shapiro projects is, it's a very contained, short amount of time in general. And so there is this little bit of risk that you can have scope creep. You propose a certain project, and then over time, other things look interesting, and before you know it, your project has snowballed into this giant thing. It's very tempting, but you have to resist the temptation. The smaller it is, the more likely it is, of course, that it will be feasible, and you want to be able to get it done during the time you have, because then you have to head right back to classes. The other thing to think about is, depending upon your type of study design, you want to think about, am I testing a hypothesis or am I generating a hypothesis? And both of those things are equally important. But why is that important to distinguish in terms of whether it's testing versus generation, do you think? And yeah, so the study design, right, will differ based on whether you think you have the data to generate hypotheses or to test them. So for what is an example of a study design that is generally used to generate hypotheses, when little is known about something and anything that you find is valuable? You're going to read a lot of them in your medical school training. So case theories, case reports, first description of a new disease or something that is little is known about. An example is the recent Ebola outbreak, a few years ago. Ebola had been around in Africa for many decades, but because this was the largest outbreak in history, really, besides the terrible things that all happened that needed to be dealt with, it also gave people the opportunity to really study the natural history of the disease. And so many things came out that people had no idea about. So it wasn't something that you could test the hypothesis immediately, but you could generate a lot of things. For example, how does Ebola get transmitted? We always assumed that it needed to be close personal, direct contact, but that's clearly not the case from what we learned as the outbreak progressed. So that's an example of hypothesis generation. And if you wanted to test it, what sort of study design would there are many, but can you get an example of a design that would lend itself to it? Well, what about a randomized controlled trial? Right, that's the gold standard for hypothesis testing. You're hypothesizing that drug A is better than drug B for reducing mortality for whatever condition you're interested in. And you can directly test it by giving some people A and some people B, and then seeing whether your hypothesis is proven or disproven, or accepted or rejected is the conventional terminology. And one thing that I think we have learned over the years with these projects and others is that it's important to set up right in front, before you even start data collection, what success will look like for the project. And that's very individual. All of you will have done that with your mentor when you put the project together. The process is as important as the outcome, but it's entirely possible, right, that if you're doing a project where you're collecting data, that you may find that the question of interest doesn't really pan out. So if you're looking at readmissions, for example, with a particular entity, and you find that actually there's no increased risk of readmissions, ideally, the question should be important enough that whether the results are positive or negative, they should matter. And so this would be important to discover right with your mentor at the beginning. What if I don't find any positive results? There's lots of things to be learned from the process, and that's the nature of research, is that not everything will pan out exactly the way that one would like it to. So that's why the close collaboration with mentor. How many of you are meeting weekly with your mentors, the primary mentors? Great, so most of you, okay. That would be important, especially right up front as you start. Let's talk a little bit about the need for a literature review. Let's just throw out some ideas for why a focused literature review is important, do you think, for all your projects? There are many reasons, of course, but.
There's an idea of what's already been done.
Exactly. So it allows you to put your research in context, and that will come in very handy when you are trying to do it and also when you're trying to write it up. If we're doing nothing but replicating what's been done, that's still important, but of course there's a gap that you want to be able to fill. And so the main thing with a focused literature review, just as you said, is you have to discover the gap. What is the gap in knowledge that you are going to close with your project? Other reasons to do a literature review?
It also allows you to compare what you're doing with other people, like see what they found, see what you're finding.
Exactly. So are you corroborating the results of previous studies? Are your results different? And if they're different, then you'll have to come up with a reason why they're different, whether it's study design, more rigorous, done differently, different patient population, et cetera. So it's of course important to do, a lot of background reading, and you'll have done that when you develop the project. But at this point, it's the focused piece that's important, where you want to dissect the papers that you have identified as important to your project and identify pros and cons to them. So when the time comes to write the paper with your mentor, and in the discussion section where you're putting in, these are our findings and this is what they have done to the rest of the body of knowledge around this topic. I usually recommend that people create a box folder or something like that and start putting papers in there as they develop them, and annotate those papers and read them, once, just do a general read for the abstract, just to get a sense of what the investigators are about, and then do a deep dive into the specifics. So what's the most important part of a paper to read when you're doing a focused literature review?
Methods.
The methods, exactly. Because the methods are what are going to either distinguish you or make you the same from the others. So the methods are really important. And the reason the methods are important is because some of the variables that you will want to adjust for example, if you're doing a project where you need to adjust for confounding, you're going to want to know what are the variables that I should be collecting to be able to adjust for confounding. And that's where the literature will guide you. Not just what the variables are, but how they were defined, how you should know, how is acute kidney injury defined in papers that are looking at the similar topic, and then how would you handle that in yours. Time can really run away with you very quickly. This is a short, focused project, and so every week when you meet with your mentors, make sure that you review the timeline and revise it based on progress or whatever, whatever issues may have come up that need to be resolved. It is very rare for a Shapiro project to be completed, from beginning to end exactly on time, but the closer you can get to it, the more likely it is that you'll have something tangible at the end of it, if that was one of your goals, whether it's being able to present the work or whether it's being able to write the work and submit it for publication. Obviously, a project that was important enough for you to have dedicated so much time and effort to do it, I think, deserves publication. So we always encourage that, no matter what the results are. But that might take a little bit after the Shapiro timeline is done. And then, of course, going over it each time with your mentor every time you meet, just to make sure that there's no new things. How will you keep track of how the literature is evolving during these 8 weeks? Supposing you're doing a systematic review, how will you know if one has just been completed during the time frame that you're doing this project, such that you have been scooped and now you have to do something different? Has everybody signed up to MyNCBI on PubMed? So if you sign up to my NCBI and make an account and put some alerts in, an alert will pop up in your email every time a paper is published on your topic. You will have done a literature review at the time you wrote this proposal, but obviously things keep coming up all the time. And so when you get that alert, then you can look at it and see if it's something that's very close to what you're proposing to do. There's always ways to get around it. You know, it's rare for a paper to be exactly the way that you had intended for it to be. But of course, you'll have to address it. And the discussion will change somewhat, because now from saying that there's been no systematic review conducted on the topic, you may be saying that there has been one other one, and what yours is different compared to that one. It is important to answer the so what question. And this is, you know, a lot of what your mentor will be talking with you about at the time the proposal was generated. It has to be important enough for people to care about it, such that no matter what the answer is, people will still want to read the paper. And all of the way that you've all described your project, they all seem very interesting, clinically pertinent, and so I don't think that will be an issue. But when you write the discussion, that's an important thing to bring up right away. Why is it that people should care about your findings? And again, that goes back to the gap. If there's a gap that you filled, however, you know, you don't have to fill it all the way, but whatever knowledge you've added, that should be. And then, you know, why you are trying to answer this question. And of course, I think in your case, you discovered your mentors because you were interested in a particular topic or a particular area of specialty. And so that typically is not a problem with a group of like this. Ideally, the results should be interesting, no matter whether they're positive or negative. One thing to think about for chart review studies, we start out with a single question that we're trying to answer, but you might be reviewing, you know, hundreds of charts depending upon your project. And if you are doing that, then try to ask more than one question so that you can get more than one publication out of the same data that you've collected. It's easier to do than one would think. So for example, if your primary outcome is mortality, you know, you can also add other outcomes. You can look at admissions or readmissions, or in my case, I might look at antibiotic use in addition to C. diff. I might look at length of stay. Just because if the first question, for example, doesn't turn out to be as interesting as you would have liked, then you still have the option to look at other things. If you become too focused with chart review and it's a negative study, then people sometimes have trouble figuring out, well, what can I do with this and where should I publish it? Again, reminding people, keep the project small and just review the timeline several times, at least once a week. Has everyone had some experience in creating a conceptual framework when you were writing your project? Does that ring a bell? So a conceptual framework at any stage of the project is important, but it helps particularly at the inception, but also when you're doing it. And so what do people think a conceptual framework might be? And what would be the purpose of doing it, do you think? Any thoughts? Well, one way to think, and there's many ways to think about it, but one way to think about it is it's connecting your question with the outcome of interest. And it's trying to devise a mechanism for how you will get from A to B as far as the research question goes. So for example, if I want to look at, do probiotics increase the risk of C. difficile infection in hospitalized patients? Making a conceptual framework in the form of a figure will require me to make multiple boxes. In one, I will put what my exposure is, which is probiotics. All the way to the right, I will put down what my outcome is, and I have to find a way to connect the two together. And so what would be the mechanism? Why do I think that probiotics might have an influence on whether C. diff is caused or not? So one idea could be, do I think that it affects the microbiome of the gut because C. difficile is a disease of gut dysbiosis, and if I were to replace the gut microbiome in the form of probiotics, I might see a lower risk of C. diff. But putting that explicitly in the conceptual framework helps you to think about the gaps in the data that you're collecting. So now I've said that I think it's the microbiome that it's important, but I'm actually not collecting any data on the gut microbiome, right? So when I write the discussion, I will say, yes, I think probiotics are important, or no, there aren't, but a limitation is that because I didn't collect data on the microbiome, future studies or I will, as the next step, need to do that. So it really makes very specific what your question is, and most importantly, it links the two. If there's no connection between the exposure and the outcome, then it makes you wonder, what is the basis for the study question at all? So if you Google conceptual frameworks, you will come up with many. It doesn't have to be overly complicated. It's really just a series of boxes linking the variables with the outcome. And that's why the next step is very important, that you have to list the variables that you need, and you have to be very explicit about them. So for all the clinical projects that require primary data collection. Some of you are already coming with data sets that are being given to you for analysis, and that would be different. But even there, you need to determine what are the variables that you need besides the usual, age, sex, race. Sometimes if the data is reliable, and then whatever other comorbidities and other confounding types of variables. So what is the difference between quality improvement and research? A lot of Shapiro projects straddle this line between what's quality improvement and what's research. So what's the difference, do you think?
Yeah, maybe I would say that quality improvement is a process where a clinic or a facility want to improve upon treatment. So they want to measure and see how they can implement certain policy or certain intervention in order to improve upon their study, to improve upon their old or their usual intervention. So with that, it's going to give them a clue of what is really going, whether the new policy or new intervention is improving or is not improving.
Yeah, exactly. So for quality improvement, you need to demonstrate that there's a quality gap. And even though when you read about quality improvement, there are of course many multi-site quality improvement studies, but at your level, it's generally a local issue. In our UW Health patient population, we find that X number of people are not being screened by hemoglobin A1C periodically. The national guidelines recommend that it be done this frequently. We find that we're not doing it. So that's a clear quality gap. The difference is that research generates new knowledge, something that wasn't previously known, however small, but still important. Whereas quality improvement is a way to close this quality gap and may or may not generate new knowledge. It may teach you ways of how to do things differently, but generally the discoveries that you're making are things like there are barriers in the health system that are preventing you from closing this quality gap and how to close those barriers. Both are entirely publishable, both are important, but it is good to make that distinction because when you write the paper, if you write quality improvement as research, that wouldn't be accurate, and if you write research as quality improvement, that wouldn't be accurate. So you just have to be clear about what those two are. What are the regulatory considerations? I mean, what is different between QI and research from the regulatory standpoint? Yeah.
I think that QI can typically be exempt from any IRB review, whereas we've got a research pathway to go to the IRB review.
Exactly. So the IRB makes the determination, and sometimes if the line is so gray that you don't know whether it's QI or research, then the IRB can help us make that determination. But on the health sciences, IRB is a great tool for determining whether your project is QI or research, and you answer those questions, and then it comes up with a pop-up box that says, it looks like your project is QI, therefore you do not need IRB review. Again, when you write the paper, this is going to be important because reviewers will want to know, is your project IRB approved or not? And of course, you wouldn't want to do any research without IRB approval from the ethical and regulatory standpoint. Statistical considerations is something, these are all just things that have come up in previous projects, and that's why I bring them up, is that oftentimes we involve the statisticians toward the end of the project. You have a data set and you take it to them and you help say, can you help me analyze this? And the ideal approach is to involve them right at the front end of the project, such that they can help you create your data set while you're collecting your variables. It's very discouraging to find out at the very end that some key variable that they need you forgot to collect or didn't know you had to collect, and now you have to go back and review 300 charts. Do all of you have access to a statistician, do you know, or have had some support? Okay. And they don't have to be involved entirely throughout the project, but definitely heavier up front, and then of course at the end when the time comes to analyze. How do you review your quality of the data? How do you know that it's the way that is intended to be? Who is doing a study where they're reviewing charts or collecting data? Anyone? Yeah? Okay, so you're reviewing charts and putting data in, and what sort of checks and balances do you think we need to put in to look at the quality? Well, one is, and you probably are doing this, is to make a data dictionary and a code book, right? Because people's definitions can vary, and we have come across so many of these in my own work. But for example, again, if we go back to the probiotics and C. diff work, if I'm doing a chart review study looking at these two questions or looking at this question with these variables and other ones besides, the first thing that will come up is how do I define a probiotic? If I'm the only one doing a chart review, even I can get confused from time to time. So even though I think in my mind I know what a probiotic is, but if somebody comes to me with, and they say they're taking twice the usual amount of yogurt, and the yogurt says it's a probiotic yogurt, am I going to consider that a probiotic or not? If not, why not? The same thing with C. diff. If somebody has diarrhea and they get a single C. diff test that's a PCR, but the diarrhea resolves without treatment, am I to consider that a C. diff episode, or is that not a C. diff episode? So for reasons like that and others, you'll want to make sure that you have a data dictionary that clearly defines, and then you want to pilot that data dictionary, especially if two people are doing chart abstraction, to make sure that both of you arrive at the same answer for what you think you are. And if you're not in agreement, then a third person can be the arbiter, but that's one way to check for data quality. The other is to run frequency checks periodically. If you're putting in an Excel spreadsheet and say gender is one of the variables, you run a frequency check, you find somebody's 140 years old. Well, you know that that's somewhere where you made an error in typing it. This is also useful to tell you whether there's a lot of missing data and whether your question can actually be answered the way that you think it can be. So if I'm looking at probiotics and C. diff and I find that in UW Health and EPIC documentation, there's hardly any documentation of probiotics, if I were to do a frequency check, I would know right away that this is probably not a question that I can answer using this method. I probably have to go and ask patients directly if they're taking a probiotic or not. And I can tell you, at least for this question, what's in the EMR is not a reliable indicator of probiotics because they're available over the counter, so everybody can take them at any time, and we typically don't ask that specific question. So there are limitations of chart review types of studies and any type of research, really, and so the frequency checks are useful there. So this is the hierarchy of study design sequence. So right on the top, you can see those are the hypothesis generating study designs, and at the bottom are the hypothesis testing. What can you sort of, when you read a study, how can you determine quickly whether it's a case series versus whether it's a case control, a cross-sectional, or a cohort study? In other words, is it descriptive or is it analytic when you're reading a paper? What's sort of the key distinction between those two major categories? So what's the difference between a study that says description of the first 100 patients with Ebola virus disease? That's one. And the other is evaluating risk factors for mortality for Ebola virus disease. In the first example, is there anybody in the group that doesn't have Ebola? So is there a comparator? No, because it's just a description of the first 100 patients. So everybody has the outcome of interest, which is Ebola in my case. And so there is no comparator, so you cannot compare risk factors or generate them. And so that's a hypothesis formation type of study. So that would be a case series. And that's one quick way to determine whether something is descriptive epidemiology or not. Anytime there's a comparator, it immediately becomes analytic epidemiology. And among analytic, then there are the various other study designs that you can do. Clinical trials are typically, somewhat easy to distinguish. If it's a randomized controlled clinical trial, it'll say that in the title, and you can verify that from the methods. But there are many other variations on clinical trials that aren't as easy to distinguish. So again, descriptive is case report, case series. Do you need IRB for a case report or a case series? It depends how big it is. For a case report, no. You often might need patient consent. Some journals will require you to do that. For case series, again, if it's a series of 4 or 5 or so, then generally not. But anything more than that, yes, talk with IRB. And then those are the analytic studies, so cross-sectional, case control, and cohort. You can see that there's a lot of variations on the experimental studies. RCT is the gold standard, but there are many others where it's either not feasible or ethical to randomize, and so what are some other ways that one would have to look at that? So to the extent possible, try to put a study design to your study and see which of the categories it falls into. What kind of study design is this? You've selected some records for your study. You have subjects, that's again staying with the theme of probiotics. Some subjects are exposed to probiotics, some are not exposed to probiotics. We're going to call those controls. And then we're going to follow them, and we're going to see who develops C. diff and who doesn't. You can either go prospective or you can go retrospective. If the data is already in the EMR, you can go backwards. So if you start with the exposure, what sort of study design is that? So this would be a cohort study, right? You're starting with the exposure and you're either going backwards for the outcome or you're going forwards for the outcome. But anytime you start with the exposure, it's a cohort study. And so what's the advantage? Let's talk about maybe one advantage and one disadvantage of a cohort study. What might you think? Supposing you're going forward in time, right? I've collected some patients on one of the wards. I'm trying to figure out if they have probiotics or not. Now they're getting discharged, and now I want to follow them up for C. diff. So what could happen?
It's easier to get stats if you're starting with the exposed group than with people that aren't exposed and the low chance that they go on and develop that.
Yeah, so you, from your power and your sample size calculation, you want to make sure that what you're studying is reasonably frequent that you actually have a chance of answering the question. If C. diff is so rare, and if it's going to develop 10 years after the exposure, it's not practical for me to do a cohort study during my time in the Shapiro project, right? Or for any other reason, really. So you want something that is reasonably frequent to be able to do that. There are many cohort studies that run for years and years, so it all depends, on resources and on money. But that is an important consideration. What else might happen? I mean, do people always let us know where they're going when they leave the hospital? They always pick up their phones. So attrition, right? Attrition is a real concern in cohort studies because you're following people up over time, especially if they're prospective. Even if they're retrospective, if you're relying on the EMR to tell you whether they had C. diff or not and they went off to a different health system or they moved across town or whatever, then you're not going to have that. So they will be missing data, and there is absolutely nothing that one can do reliably for missing data. So it is really important to avoid dropout. You can try and do multiple imputation. You can try and predict in your mind what might have happened had they not dropped out. But realistically, once you get to a certain point of missing data, then the question cannot be answered. So that is really important. And that's where the frequency checks come in for the retrospective collection. If I were to undertake this study, I would do a quick frequency check of probiotics in the EMR, a quick check of C. diff in the EMR, and see whether A, there's enough numbers for each, and then B, is there a lot of missing data in the population or not. If I have those, then the rest of the confounding variables are the next step. So attrition is one, expense is another, and then the other thing is misclassification, like we talked about. How are we defining exposure? Is a probiotic defined as one capsule of XYZ 2 times a day? What if somebody takes it 3 times a day? Is that still exposed, not exposed? And then what is the unexposed? If somebody by mistake takes a single dose of a probiotic, can I still consider them unexposed? Because what is the risk of misclassification? What am I running the risk of if I don't accurately define who is exposed and who is not exposed? Well, one risk is that I can dilute my exposure and unexposure, right? If people are taking probiotics willy-nilly and I don't take care to categorize them, it's possible that the controls aren't real controls because they're also exposed. And if that's the case, then I'm less likely to find an answer to the question of, do probiotics cause C. diff? And that's called an internal validity problem. The ability to answer the question the way it should be answered. If we can't do that, then it runs into internal validity issues, and those are hard to get around. How about this one? What sort of study design is this? So now you have your people or your charts, whichever, and now instead of the exposure, you're starting with the cases. And so the cases in my instance will be people with C. diff, people without C. diff, and now I'm trying to find out how many got probiotics or didn't get probiotics. So you see the distinction? Before we started with the exposure, and now we're starting with the outcome and going back for the exposure. So what study design is this? Case control, exactly. So the cases are C. diff, the controls are non-C. diff, and then we'll go back. So one advantage and disadvantage of a case control study. Once you practically start doing your project, if you're undertaking the study design, you'll realize the issues with it. Well, the advantage is that everything in terms of the data is already present. Generally, these are retrospective, and so even if it's somewhat of a rare disease, you will have that data in your data set if you have enough population. So for rare diseases, case-controlled studies are better because you don't want to follow people for 10 years to see if they get the outcome or not, for the most part. They're also cheap to do for that same reason. What's a major disadvantage is the selection of the controls. The selection of the controls matters because, as we talked about with the PICO question, that's what your comparator is going to be. And so what might be some controls, for example? Say my cases are people on a certain ward in our hospital who have C. diff as defined by diarrhea and a positive test. So that's my case. What are some choices of controls that I could use? People without C. diff, right? But how is without C. diff defined? What if somebody has diarrhea and a negative C. diff test? Is that my control? Or is it somebody who's just hospitalized at the same time as the case but didn't have a test because they had no diarrhea? Is that an acceptable control? What about if somebody had diarrhea for a little bit of time, weren't tested for C. diff, could they be an acceptable control? So there are lots of possibilities for control, and each one has its advantage and disadvantage. But the important thing is to specify it right up front so that you can be consistent in your selection of controls. The same thing is true really for any topic that you care to think about. There are many choices for controls. Generally, for hospital-based cases, hospital-based controls are a good idea because they are very similar in all respects to the cases, except for the fact that they didn't get C. diff. And then you can look at the probiotic issue. And this one is what is the study design? I mean, it says that, but so it's an experimental study, right? So you have a group of people. You are assigning them some to intervention and some either to placebo or another active intervention, depending upon the study. And then you're looking for outcomes. If you randomize them before intervention or placebo, then this is a randomized controlled trial. If you don't randomize them, which many times it's not feasible to do, then it's still a clinical trial, but it would be considered a quasi-experimental clinical trial because it's the randomization that gives the clinical trial its strength. So if you can't randomize. And so speaking of randomization, why is it a strength of a study design? Why do we care so much about RCTs?
Is there controlling in theory for confounding variables?
Yes, exactly. So if you randomize, you are taking bias out of the picture, bias meaning investigator-induced bias, because you are not controlling who is getting what. And so in theory, everything should be adjusted for, and the analysis at the end is a very simple chi-square or other comparison between people who got the intervention and people who got the placebo. That's why an RCT is such a powerful design, because it is very simple in concept. It's very hard to execute in practice, and really not practical unless you're already part of an RCT during the time that you have. But it's still important to recognize the strength of that study design. All right, so let's maybe 9:35. So we have time for questions. What sort of questions or comments come to mind about your own projects and whether you can apply any of these tips to your projects? Yeah.
This isn't about my specific project now, but I was working on a project in the past looking at like risk of thrombosis. So how do you narrow down, because it was one of those things where there was just an infinite amount of variables that we could have controlled for.
Mm-hmm.
Like there was obvious, like, you know, were they on an anticoagulant? Did they have a history? But then it's like, were they on birth control? Did they have factor V light? And there's just more and more things we could have added. So how do you kind of, when there's infinite possibilities, decide which ones you make?
Well, you are going to be quite constrained by your number of outcomes. So for every positive outcome, at most you can have about 10 variables. Otherwise, your logistic regression model will not converge and will not be a robust model. So it's a common error that we make, is that we think we want to collect all these variables, but when the time comes to actually analyze them, you can't put all of them in the model. So they're not useful from that standpoint. So you have to pick, supposing you have 100 people who had thrombosis in your group, for example, at the most you're going to be able to do is a few variables. And so 10 tops. And so think about, from the clinical viewpoint, what are the most important ones, and then don't include the rest. It's often a difficult decision because people want to collect more, but it really doesn't work out in the long term. And so that's a question where a discussion with the biostatistician can be very helpful early on. And I recommend that people show them, whether it's Excel or whatever spreadsheet you're making, show it to them, and they can tell you whether it'll be a concern when the time comes to analyze it or not. Generally, focused reviews are much better than the converse. So Eric, since I know you quite well, I feel I could put you on the spot. So do you want to talk about what your study design, what you think it is for your povidone iodine project?
My study design, it appears to be, it's not a random disease. So,
Exactly.
So it's like quasi-experiment.
Exactly.
Yeah.
Yeah.
But
Mhm.
there's one question that I still want to ask.
Yeah.
Because I'm implementing this study, and we want also to check fidelity, or we want to check the effectiveness of the povidone iodine, and then the implementation aspect. So I'm wondering, is it possible that you can do the implementation only without assessing the effectiveness of the drug?
It is possible. Maybe let me ask the group, what is efficacy? How do you define efficacy? Say if you're testing a drug. In our case, let's say maybe povidone iodine. So efficacy would be how the drug works in the what setting? Real world or ideal setting? The ideal setting, right? And the ideal setting is generally a group of very homogeneous patients where most people have been excluded because you think that the drug might not work well in them, so the immunocompromised population or others, depending upon the question. So in the ideal setting, does the drug work? Does povidone iodine reduce surgical site infections? That's an efficacy trial. And an efficacy trial generally is a randomized controlled trial, generally of large enough size, and it is meant to answer this question, does it work in the ideal setting? That's the first sort of necessary step. But then the more important next step is it effective? And the difference between efficacy and effectiveness is that whereas efficacy is in the ideal situation, effectiveness is in the real world setting. So in my setting in UW Health, if I were to implement povidone iodine, would I see a reduction in surgical site infections? And the reason I might not is because now I'm not trying to do a randomized controlled trial. I'm going to do a quasi-experimental study where everybody that comes into transformations is going to get a swab of nasal povidone iodine, and I'm going to follow them up passively to see if they get SSIs or not. It's quite possible that some patients are at such low risk of SSI that they were never destined to get it, and therefore the effect of povidone iodine is now diluted. So it won't have the same positive results that we saw in the efficacy trial that was done in the ideal setting. And so once you have the efficacy trial, for the effectiveness trial, I think it's important to look at outcomes. But you can also just say, I know that this works in multiple trials and in multiple settings. Now I'm just going to look at, can I actually do it? And that's where the implementation is, And when I say can actually do it, that would mean talking to nurses to see are there barriers to actually doing the povidone iodine. Is there a shortage of the product? Are people having trouble distinguishing what it looks like? Is it sitting on the shelves only to find that it's expiring? So those sort of practical implications are what effectiveness is important for. The efficacy often does not. They should look closely at that, but many trials don't look as closely at the fidelity as they should. So what are the problems with a quasi-experimental study compared to an RCT? You're giving away sort of the gold standard thing, right? You're not randomizing. So all the biases that we talked about for a cohort or case control study can also happen in a quasi-experimental study. An extreme example of a quasi-experimental study in quality improvement is when we thought that reduction in C. diff rates was due to an intervention that we had implemented, only to find that the intervention had never been implemented in the first place. So things that are done in healthcare systems, we think they're happening, but to Eric's point, when you look at fidelity, I should have gone back and checked, when did the intervention start, who was doing it, how it was being done. But because we assumed that just because we had said it was going to happen, it would happen, we found that it actually never really got off the ground. So treat quasi-experimental studies much like you would observational study designs because they have those same limitations and those same biases. All right. There'll be more on this in the series of next talks. I do want you folks to fill out some evaluation forms. I'm going to pass these around.